So, why are we interested in osteoporosis? It's probably one of the most important but under-recognised and under-managed, that means under-treated, problems that we have in most Western societies today. It is common in both men as well as women, and it's in the relatively young, old, that should say. So when I say the relatively young, as it happens, where my age is now, it's almost exactly at the peak of the occurrence of osteoporotic fractures, fragility fractures in the Australian community. And I consider myself not terribly old, so I think it's in the relatively young then. The other thing too is that people have ideas about osteoporosis, including in the medical literature, that there are some really typical fractures, but none of the others count. So, you know, a spine fracture, the sort of thing that leads, unfortunately, someone to be bent a bit more like that, or a hip fracture, people recognise those. They don't happen to do too much about it, but they recognise them as being osteoporosis. But in reality, any bone that fractures under relatively minor force signals that there is a problem, and it signals that there's increased risk of further fractures. So if you have one fracture, if you're a man or a woman, the risk in a man is about half that in a woman. Okay? If a woman has one fracture, her risk of another fracture goes up about twofold. For a man, when he has one fracture, his risk of another fracture goes up fourfold. So the protection of being man disappears. And it's about the same increase in risk as someone being 20 years older. I'll show you some of that in a little while. The other thing which is really very concerning, and it's come from the work that we've done here, much of what I'm talking about has come from the work that we've done in Dubbo over the last 25 years. And that's been an incredibly productive resource. And just to come back to the work that people like yourselves have done in terms of supporting Garvan, frankly, we could never have done it if we depended on the standard funding sources, because their level of support has been abysmal, despite this being really changing the world perspective about osteoporosis. But the other thing that we found in that study, when I say we, I'm talking about other people. A lot of other people have done this work, particularly Professor Tun Win and Professor Jackie Center, who've worked with me for a very long time. The other thing that we found out is the risk of dying goes up after an osteoporotic fracture. Now, that's not, even when I was a student, they said, oh, you know, somebody has a hip fracture, their risk of dying goes up. And we said, yeah, well, of course, you know, there are operations, there's illness, blah, blah, blah. But in fact, what we and others have now shown, and what we've found and been being reproduced around the world, is that most of the increase in risk is not explained by the actual fracture per se, but it's signalling something else. And people who have any fracture, both men and women, and again, it's actually worse for men than women, their risk of dying goes up quite substantially. But there is, however, some good news that I'll come back to, and that is treatment reduces that risk. And just to put it in perspective, the direct and indirect costs of osteoporosis is about $7 billion in Australia, $7 billion every year. You can think about that two ways. One is to say pretty much $1 a day, every single day, from every man, woman and child in Australia. That's the cost. If you want to look at it another way, you could say that it will have cost Australia probably $2 or $3 million while you've been at this seminar. So it's a significant issue. And the really sad bit, and it's really this bottom line here, is that in Australia, and it's true around the world, the majority of people who have a fragility fracture that really didn't need to happen, do not get treated to reduce their risk of another fracture. If you're a woman, you've got about an 80% chance of not getting a specific treatment to reduce the risk of another fracture, to effectively reduce the risk of another If you're a man, it's about 90 to 95%. That you will not get treated. And this is the same around the world. It's challenging. Now, what do we mean by a fragility fracture? So, if I'm standing up here and I fall over and I break something, that's almost certainly a fragility fracture. I'm not allowed to walk over there, but if I walked to the end of the stage and fell off and broke something, people say, well, what do you expect? You fell off the stage. Or maybe off a building, or got run over by a car, or hit by a train. But not the simple falls. I have a different way of describing it. I always say to people, because the people that had the fracture were probably the only one who was there at the time, if this exact event had happened when you were in your 20s and 30s and perfectly healthy, would you have expected to fracture? Unless you can say yes, that's probably a fragility fracture. I'm trying to introduce a slightly different term, a term bone failure. We're used to things like heart failure, lung failure, kidney failure. But if a bone breaks when it needn't have, that's bone failure, and it signals all the rest of what I'm talking about. So one of the first things we did when we started looking in Dubbo was to look at the fractures that occurred. And this skeleton shows where the fractures were that we saw in these people in Dubbo. We recorded every single fracture that we could. I mean, anyone who had an X-ray, we got that information. And basically, the only places where the fracture doesn't signal fragility is pretty much in the head and neck. They're the only ones that don't. Every other one of these, with two small exceptions I'll mention in a moment, indicate the people who had these fractures were then more likely to have other fractures. So it's the same problem. The only ones that didn't happened to be rib fractures in men. Maybe because they get involved in fighting with people and get their ribs cracked, I don't know. But in other studies, they have been associated. And the only one that consistently shows as not being related, weirdly, are ankle fractures in women. Ankle fractures in men, yes, but ankle fractures in women, no, and we don't know why. Maybe it relates to high heels or something like that. But everything else signals it. So one of the first things that came out of the Dubbo study was to say, don't think about osteoporosis just these few things. It affects all bones, and it affects men as well as women. So why do we get a bone that breaks? And this is sort of a diagram to try and represent this in some way. You have, on the left here in the green, you have how much bone you have and how good it is. Makes sense? On the right over there in red, you have something that probably relates to the likelihood of there being an injury. Are you unstable? Are you weak? Do you have slow reflexes? Are you unable to protect yourself if you start to fall? You know, some of the most remarkable ones you see are people who are carrying things when they fall. And then they don't use their hands to protect themselves. And they fall and they injure themselves often quite badly. So being able to protect yourself in a fall. And all of this means you have an interaction in the middle there between how strong the bones are and how much trauma occurs. And it's a pretty obvious thing. If the trauma is more than the strength, you have a fracture. If it's not, you don't. Very simple concept. Now, one of the things we do, and has made a huge difference in this area, is being able to get bone densities done. And this, I won't go into the technology, but essentially it's an X-ray based method, and it works out roughly how much bone there is in your bones. Knowing that by itself is not terribly useful. You have to compare it to something. And we compare it, there are different ways that we can do it, but we can actually measure the value. But we also use something where we compare it to people of the same age, which is sort of helpful because it tells you if somebody's particularly low compared to somebody of their age. You can think, well, there's something else happening. But there's so many things that get worse as we get older, it's not much use doing that. So we use another comparison, which is to young normal. And this is something which we call a T-score, in that red box up there, T-score. Doesn't matter why it's called that. And it just gives you a number of units that you are away from what you expect in a healthy young normal person. What's interesting is a group of guys and they actually all were guys, sat around in a room in Geneva, looked at some of our data, looked at some of the evidence of fractures in the community, and said, well, we're going to say if you get a bone density more than 2.5 standard deviations, which is what a t-score of minus 2.5 means, below young normal, we're calling that osteoporosis, and that's stuck. It's not based on anything more robust than that. What's interesting, and if you look at this green line here, I don't know whether you have something I might be able to point with. I don't know if you can see that green line there. That is the risk of fracture that we saw over 10 years in people where we'd measured their bone density. And what you... Oh, sorry, I didn't mean to do that. Okay. And what you can see... Maybe I'll just give up. I keep doing the wrong thing, I'm sorry. And what you can see is that this risk just gradually increases. It's what we call an exponential curve. This is this value that we call osteoporosis, but nothing magically happens there. The risk just goes up continuously. This curve here is the plot of the actual number of people we saw with each of these different bone densities. Now, just to the right of this line is what we call osteopenia. It's probably the only logical thing in there. So you have normal over here somewhere, then you say you have osteopenia, which means less bone, then you have osteoporosis. But nothing magically happens there. In fact, if you look at the risk here and the number of people here and here, there are actually many more fractures that occur in women and particularly in men in the area that we call osteopenia. Because there are so many more people, even though the risk is a bit lower, with many more people, there are actually more events. Now, we looked at a couple of other things in Dubbo, and I'll mention them. One is we measured how much sway people had. And these are, we just divided, it doesn't matter how we measured them, we divided them up into different groupings of how much sway people had. If you had more sway, here you were in number 5. So looking at the first two sets of columns on the left. And what we can see is the risk of fractures increased as you had more sway. It's not too remarkable, frankly, but this is what it shows. This was true in both women and in men. And on the other hand, if we looked at how strong your thigh muscles were, your quadriceps, you can see that the weaker your muscles were, the greater the risk of a fracture. So what it's sort of making sense. On the one hand, as your bone density goes down, your fracture risk goes up. As your muscle strength goes down, in other words, your protection and maybe some other effect on the bone, your risk goes up. As your sway goes up, your risk goes up. So we put these together, and again I say we, but this was in fact the work of Tun Win, who I mentioned earlier. What we found is that if we looked in the people in Dubbo, we could identify basically 5 things that were very useful for predicting the risk. How old you were, what sex you were, how good your bone density was, or actually we could use weight because those two are fairly strongly correlated. If you'd had fractures after the age of 50 and how many falls you'd had in the past year. And this allowed us to predict how many fractures you might have, including how many hip fractures over either 5 or 10 years. And we use both because we say to somebody, oh, in 10 years this will happen, and people say, oh, no, doctor, I'll be dead in 10 years, you know. We say, well, over 5 years then. But anyway, so you see those 3 words at the top there after Garvin, fracture risk calculator. You can either put those into your web server, or if you're like me and you need someone younger to do it, get someone younger to do it. If they put in those 3 words, Garvin, fracture risk calculator as one word, it'll lead you to this website on the Garvin where you can put in your information and estimate your risk. Okay? Now, we applied this, we developed this, and then we did an interesting study. This was done in one group of people in Dubbo. We wanted to know, did it work? So we collaborated with some people in Canada, probably one of the largest osteoporosis studies otherwise in the world. It's called CAMOS, the Canadian Multi-Centre Osteoporosis Study. And they gave us the information on individuals We calculated their risk and sent it back to them. They divided the risk. We divided that risk then into 5 groups. Q1, 2, 3, 4 and 5 for men and for women on the right. And we've done this both for hip fracture and any fracture. And what these diamonds was the incidence that they saw of fractures in their people, in their population. And it's embarrassingly good. You know, these little diamonds are almost sitting exactly on the top of the box. In other words, in a totally different population, across the world, across the other side of the hemispheres, whatever, what we'd worked out in Dubbo worked very nicely in Canada. And this is something which is being used now around the world. That website that I'm mentioning can be accessed from anywhere. It gives you the risk. Okay, so what can we do about osteoporosis? There are sort of 3 different levels. You can say, let's talk about public health. So one of the things that people argue about is regular physical activity, adequate calcium and protein intake. Dairy happens to be an incredibly good source of that because it has both calcium and protein, which is probably important. We advise people not to smoke, to drink less than their doctor, to avoid that, and to do whatever else they can to minimise falls risk. Okay, that's, if you like, the public health approach. They're the messages. It costs nobody anything to tell you to do this, right? The other one is, say, let's identify people who have low bone density. We know those people are at increased risk. The evidence is clear. And we can say, look at people who are older, who are lower in weight. We can base it on family history. Let me tell you, for almost everyone in this room, the most important thing that you have done about your risk of osteoporosis is choosing your parents wisely. It is very, very strong. About 3/4 of the risk was determined the nanosecond you were conceived. Unfortunately, there's not much we can do. And cortisone, which is used very commonly as an incredibly important and valuable treatment for so many conditions, that we know is not very good for bones, and that is something that we know is a risk. So we could focus on those people. And the other group, obviously you've had one fracture, one low trauma fracture, we know you're increased future fracture risk. There's a clear, from the government's point of view, there's a clear cost benefit for treatment. Everyone recognises that's worthwhile. Well, the sad part about this is public health approaches are largely ignored, usually except by people to whom they're irrelevant. So the people who are already doing a lot of exercise, when someone mentions this, they start doing more. The people who already drink 5 litres of milk a day push it up to 10, you know. I don't know about the other ones, but the other problem is that there's relatively little access to getting bone density checked unless people hit very specific criteria. Now, these have improved in Australia in more recent years, so you can base it on age, you can base it on some other things. You don't have to have had a fracture to get a bone density paid for by government. But on the other hand, they cost $150, so it's not cheap, but it's not outrageously expensive, and we spend a lot of more money on other things. Even if the government doesn't pay for it, we may want to do it so that we know where we are. And as I said right at the beginning, even after the fracture, most people aren't treated. So, just to give you an idea of how important the first fracture is, and this is a complex, this is sort of one of these research type slides. But the point that what I wanted to show you, and it's really in the first line that it's of the top and then to the men. We looked at people who came into St Vincent's Hospital with a hip fracture, and we went through their notes. It was done by a colleague and friend, Leah Port, who we still remain friends after that, although her son and my son are good friends. I heard some very mean things that she said about me as a supervisor when she was doing this. I'm sure all fair. But almost half the women who came in with a hip fracture had recorded in their notes that they'd already had a prior fracture. And as you can see, if you look at that number, 18% of those women were on some treatment for effective treatment for osteoporosis. And I'd use that word effective Because as far as I'm concerned, calcium and vitamin D and exercise are not effective treatments by themselves. Calcium, exercise, vitamin D by themselves are not effective treatments for osteoporosis. I'll come back to it. If we looked at the men, a third of the men who came in with hip fractures also had recorded in their notes they had a prior fracture. The point about that is this was not a specific, careful questioning had they had fractures. This was something that they just mentioned. So it's probably an underestimate, if anything. And again, if we look at the men, almost none of them are on treatment, effective treatment. So these are people who are coming to hospital with arguably the most serious and most difficult fracture, a hip fracture. Maybe a half of those could have been prevented if people had been treated when they had their first fracture. Really quite a worrying thing, and that was not done. Now, the current therapy criteria in Australia is that you can get covered medications if you're a man or a woman if you've had a prior osteoporotic fragility fracture. That's a very general term. It doesn't mean you have to have a bone density to prove it, but that's what you have. Or you're over a particular age and your bone density below a certain level. There's some others as well. These are being still adjusted now, so the T-score, as I call it, may come down a bit. But what happens is that we know that, I don't think it's 30%, maybe 20% of women, maybe 5% of men get treatment when they could in Australia, not limited by money, not limited by drug availability. They get treatment, and when we last looked at it, less than 10% of the population were eligible to get a bone density if they were over the age of 70 and had one. Now, we have a variety of treatments. I'll go through them quite quickly. What this shows, if we look at all of these, they all do two things. They reduce fractures by about 30 to 50%, which is, it doesn't mean they prevent them all, but it's pretty good. And they all work, and there's good evidence that it's within about 6 to 12 months. They don't work instantly, not when you have your first tablet or injection or whatever, but they work, and they work rapidly. So those are tablets. There's now an infusion that you have pretty much once a year. I won't go through this, but it's effectively showing you the same things. The risks go down. It's probably worth pointing out, I don't know if you can see that third line, multiple morphometric fractures, 0.1. That means it reduces the risk of getting a lot of fractures in your spine by 90%. So it's very good. And in this study, particular study that I'm referring to there, the mortality of 0.7 means the risk of dying went down by 30% by being treated. There's also the subcutaneous injection, denosumab now, and that also works very effectively. It's every 6 months. It's called Prolia. There's another drug. When people have very, very severe osteoporosis, the government agrees to pay for this drug, which costs about, I think, $12,000 a year. Okay, and you have it for 18 months, and this also improves the bone. I won't go into this in more detail here. If I'd drawn this diagram when I started being interested in osteoporosis, there is only one line on that graph, that red dotted line that says fracture risk. It would have said, as people got older, the fracture risk went up. We didn't have any way of measuring bone density. We didn't have any proven, validated treatments. I haven't gone through all of them, but they're all there. Now, I talk about calcium, vitamin D, and lifestyle. I think they should be there, but we can talk about it a bit later. The last thing, one of two things I'm going to show you. One is to show you, in this work in Dubbo, we looked at people, these bottom 3 lines on the left panel. Just need to look at that one. The blue one, the brown one, and the purple one. These are people who've had fractures compared to the dotted yellow line, which is the general population. And if we look at that, that's a general population. All of these people are people who had fractures and either didn't get much treatment. These people got some, these women, they got some hormone treatment. These were people who had just calcium or nothing. They died sooner. This is a race to zero. This is a race to being everybody dead down the bottom. And in the women who got treated with these drugs, this was their survival. The same women as these, but they actually, not only did they not die sooner than the community. They actually live long. And this translates to these people living about 5 years longer, quality of life. And it's the same in the older population, the same in men. This is now being investigated around the world to understand more about it. I think I've said all of these. I'll skip over that. Just to summarise what I've said, osteoporosis is a condition of the young old, not the old just before you get buried. It's women and men. It has a major impact on quality of life. We haven't even talked about that. It has an effect on survival. It kills people. And it costs us an absolute bomb. We can estimate somebody's risk. We have treatments that are convenient and well tolerated. They work relatively rapidly. And there are other treatments that are being developed. So we're in an incredibly positive time. Now, I would mention, just because Marie told me I should, I get in trouble if I don't do it. Marie says we have bone research here. There's a number of different things. We talk about the work I've said about the osteoporosis impact in the community. We're trying to understand why some people do worse than others. Who are the people who are going to die prematurely? If we know who those are, we know who to target. We're doing a whole lot of work on genetics, trying to understand. I told you your family is your biggest predictor. We're trying to understand more about that and trying to work things out there. There's some brilliant work by a young guy, Paul Baldock, I'm finishing now, who's working on the neural control of bone, which is absolutely outstanding. Peter Croucher and Mike Rogers, who are brilliant scientists, and Peter's now the leader of the bone program we're lucky enough to recruit, is studying bone as a hiding place for cancer cells. Cancers that come back, the bone often is where the cancer cells are hiding, and understanding in the work of Mike Rogers' novel treatment ways in which the bisphosphonates might work. So I'm stopping there, and I think I've gone a bit over time.
Thank you very much, John, for that highly informative presentation. We do have a minute for questions, and it's my fault I asked John to cover far too much information. And we had questions kind of presented to us ahead of time, and so I'm just going to ask John one question. And if you do have questions, please forward them to us, and we can get them answered after the event or during the talk. The questions, we had a couple of questions. I'm going to wrap them up in one. You did mention calcium and vitamin D, and there's a question about this. I'm suspecting myself after your talk that there's no point in taking calcium or vitamin D, but I could be wrong. The questions are about how calcium actually works and which type of vitamin D, and does exercise actually help calcium get into the bones?
Well, the answer essentially is very simple. We have very good evidence that if people have almost zero calcium intake, they will take calcium from their bones, and that's not good. What we don't have is that if you have an average sort of calcium intake, does adding much more calcium make much difference? We just don't have that evidence. There have been a number of studies looking at it. Some have suggested maybe it makes a small difference. Others have suggested it makes no meaningful difference. And there's also some data suggesting that if you have too much calcium, there may be problems in terms of heart disease. Other studies don't find that. But without good evidence that sort of drinking, they're not necessarily drinking, having a whole lot of calcium supplements, you'll suddenly get better bones, is actually for a whole lot of reasons not very logical. Having zero may be an issue. And any of you who may have seen us in the clinic will say, well, if you're having enough dairy or some other comparable source, you don't need to take calcium. If you really don't have any, it's probably worthwhile taking a modest supplement. Does it matter what form the supplement's in? To my knowledge, absolutely not at all. So people say you have to have, manganese, magnesium, silica, aluminium, zinc, horsetail, I don't know, the list goes on. No evidence for any of them. No difference they make any difference to being valuable or not. I've always thought they had a source of calcium. It had this stuff in it. They thought, we can't say it's got contaminants in it. We'll say it's good for you and charge more. And then the other thing is exercise. Again, we know if you put people to bed, young, healthy people to bed, they will lose bone. One of the biggest limitations that's ever going to be to space flight is actually osteoporosis. There's no loading. Can you imagine, one giant step for mankind? But it's very different than saying, well, how much exercise do you have? And there were studies showing that if people did a lot of extra weight-bearing exercise, very small increase in bone, never been shown that it translates to fewer fractures. And there's in fact one Australian Australia-wide diabetes study that says that people who are doing much more walking more than 5 days a week, actually had a higher risk of fracture. One of my colleagues said, well, that's because they've got a dog. And got tipped over.
Well, thanks very much, John. My lesson from earlier